Hi, everybody.
Hi.
Welcome. Hi. Can you hear me, everybody? Something's about my internet suddenly gone very slow and a bit pixelated.
Yeah, we can hear you.
Yeah, I can hear you.
Great, great. Welcome. Should we just wait a couple more minutes and see if anybody else is going to join? Hi, Rosie.
Hello.
We're just waiting for a few minutes so that people can join us. And Kira's just putting in the chat that we are going to record this session so that we can put up on TeamNet to share with people who weren't able to make it. I hope that's all right with you all. And if you'd rather not have your faces on the recording, then feel free to turn your cameras off. Great. Well, I'll get cracking. Thank you very much for giving up your lunch times to come and join us. This is the first of what we're hoping are going to be monthly, just informal drop-in webinars. We are still a relatively new team, still building the organisation, and one of the things that we're really keen to do is to ensure that we've explored all the routes and means of staying in touch with practices, letting you know what we're doing, what we're up to, answering any questions you may have, or actually hearing from you any thoughts that you might have about what we could be doing differently or better. So thank you so much for coming and being part of this first one. There's a few of us from the team that are here, and I'll introduce them in due course. But I'm just wondering, really, wanted to gauge where you are all at, how much you feel you know about GPSU or the journey that we've gone on, taking us from SPH to GPSU. Trevor, I just saw you shake your head. You don't, yeah. Shall I start?
I'm relatively new to Somerset in a way, so a couple of years, but I've been not involved, so.
No. Well, shall I sort of start, give a really quick whistle-top tour of where we started and how we are where we are now, and then we can focus a bit more on where we want to go from here. But we are the legal entity that's registered at Companies House is called Somerset Primary Healthcare, SPH, and all practices in Somerset are shareholders of SPH, which is a really valuable model and a really valuable thing in itself. And SPH was set up probably 10, 11 years ago now, to really explore opportunities for doing stuff at scale for general practice across Somerset. And I think back in those days, there were anxieties about Virgin Healthcare coming in to take over, bidding for community services or other county-wide services. And it was really a means of, so how can we as general practice come together to sort of protect ourselves against some of these external threats. I think some of you might have been around in those days. Karen isn't here, is she? No, she was going to join us. So it was set up by practice managers and GPs all those years ago who had the foresight and the vision to think, actually, this is the sort of entity that could be useful and valuable to Somerset. And then over the last 10 years, the organisation hasn't really, the opportunities for large-scale contracts didn't come along, and there wasn't really funding in the system to do much at scale. And I think there was a sense of, where does SPH fit into the wider system, and what's its role and purpose, and various relationships with different parts of the ICB meant that it never really got going or was able to realise its full potential. And with some changes at the ICB about 2 years ago, and I think probably with a view to what was potentially coming in terms of new models of and ways of contracting with general practice, and looking at what might come following PCNs, conversations started with SPH and with other parts of the general practice system around, well, what could we be doing to reinvigorate SPH and really be clear about its purpose, and what could an organisation like SPH start to be doing on behalf of general practice to relieve some of the burden of the daily grind, but equally then to start to look forwards and potentially bid for and secure funding for at-scale work. So that's where the concept of the GPSU came from. GPSU, General Practice Support Unit. In other parts of the country, organisations like us are called GP federations, but in Somerset, historically, the term federation had some connotations that weren't particularly helpful. So we avoided using the word federation and have used the term GPSU, which a similar type of organisation in Birmingham and Solihull, they've used that term as well. So the GPSU was born. We had some new members come onto the board. The board was had got down to 3 GPs, and there were some new GPs appointed. I came in as interim at the beginning of this year, and we've gone through a process really of repositioning ourselves, doing a bit of rebranding and refresh, looking internally at the organisation about what do we need if we're a startup business, which is what we feel like really. What do we need in terms of HR infrastructure, finance infrastructure, our own IT, things like email addresses. At the moment, you can see that we're using Vine Surgery email addresses. How can we secure our own digital and IT infrastructure? So we've been doing some work since I started back in February to try to put in place the basic infrastructure for an organisation so that we can then start to deliver the value to general practice that we really are wanting to. We have received some funding from the ICB. They gave us some pump priming, which has enabled us to put in place some of the core members of the team. And then they've also committed to providing us with core funding for 3 years. And that's quite unusual for organisations like us, because core funding is normally the difficult funding to get hold of. So that's going to enable us to have some HR capacity, to have some finance, to have some leadership within the organisation, put in place a bit of admin. And then on top of that, they've given us some funding for some clinical leadership. And so Barbara's going to be able to talk to us in a bit more detail about the clinical leadership that we are being able to fund across the system. And then on top of that, there's pockets of money that we have received for some of the work that we're doing around digital, around pathway interface work with secondary care, around some of the data work, and some other stuff that we can share with you a bit more about. But basically, the premise is that GPSU is new. In our minds, we're a startup, although its predecessor has been around for quite a while. I'm new in post, and we want to make sure that now we have got this vehicle, that we are really clear about what the value is that we can deliver for general practice, and hence wanting to start to share with you who we are, what we're doing, what more we could be doing, and what might be coming down from on high in terms of neighbourhood working and other contracts and models of care. So let me, rather than just talk at you, does that make sense? Is that Karen? I've just seen that you've joined us. Welcome. Karen's been around for a lot longer than I have. Karen, right from the get-go, I think. Have you were one of the people who's set up SPH from memory. So we're very much building on what went before, but also at the same time repositioning ourselves so that we hope that people can start to be clear about what our purpose is. Does any of that make sense? Any questions about what I've said so far? Trevor, have you come from another system or another part of the country, or are you new into general practice?
No, I'm not new into general practice. I've come from Surrey,
Ah,
where we
okay.
did have a federation,
Yeah.
and I was practice manager at a practice there. So
Ah,
all
right.
my
Okay.
sins.
Well, yeah. So you've sort of got an idea of the sorts of things that are happening in other parts of the country, and I guess we're similar but different.
Yeah, they're all just slightly different.
Yes.
But yeah.
Yeah. Barbara, do you want? I've talked about the fact that we have had some funding for clinical leadership and have established what we're calling a clinical reference group, or a CRG. Barbara, can you tell us just a little bit more about what that has involved, what its remit is, how you've gone about pulling that together? Oh, Karen's got a question.
Yes. Sorry, I was kind of going to wait for Barbara to answer, but obviously from a practice manager point of view, are GPSU going to have a practice manager support unit? Because I think that is a huge thing that's missing at the moment, especially with information overload coming down to practices and a disjoint, it feels, because of the ICB going through the clusters, etc. So I think GPSU to have some sort of practice manager support would be valuable, to say the least.
I think that's a really, really helpful question, Karen. And although we've got that term GPSU, it's really about general practice support unit, not just for the GPs or clinicians. So I think, in short, the answer is yes, very definitely. Two different parts to your question. One around stuff coming down from the national teams or from the ICB. Just this morning, I was having a conversation with the comms director at the ICB about how could we be supporting them or doing, instead of the ICB, some of the comms for practices. So through the filter of an organisation that has an understanding about the impact or how some of that's going to land with practices, using language that is meaningful, but also having a bit of a idea about the implication that might have. So that could be, so that's a work in progress. And we launched the GPSU bulletin 2 weeks ago. So there have been 2 versions of that now. And what our plan is to move quite quickly to incorporating any ICB comms into that one GPSU, and then talk to the LMC about how we could align that and the
great,
training hub.
I mentioned I was at the GP Careers Plus for practice managers last week, and that was one of the things I mentioned there, the fact that we have so many bulletins now, with the ICB, especially after COVID. The CCG used to give us a succinct bulletin for practices, what we had to do, but it's just duplication after duplication. So that's one of the things I was hoping GPSU could support practices with.
Yeah, well, and thank you. That's very helpful to hear that. And I think that so Sakina and the primary care team are very signed up for that as well. And we would ensure that there's a process where they know how to contribute, but they also have a sign off so that we're not going off piste and putting in stuff that isn't accurate as well. There's got to be some sort of accuracy check there. So we'll manage that process. And then I've got a conversation next Tuesday with the LMC as well about, so let's not confuse things even further. What would the remit, what would go into an LMC bulletin, which they need to have their very clear line of communication with you, but equally then what would we put in ours, and how do we avoid duplication? And I think the training hub, Beth, you've also, so Beth, let me introduce you to Beth, who's she's our new comms and engagement manager. So this is very much her remit, and the training hub has also started a conversation around, well, wouldn't it make sense to put training hub stuff in one place and not duplicate comms? So that's one of the first things, Karen.
Perfect.
Yeah.
Thank you.
And then the other, what was your other question? So practice manager support.
Oh yes.
Anything, and I can come on in a bit to just show you some of our initial thinking, but what could we remove from you in terms of burden that could be done across multiple practices once, rather than you all having to do the same thing 60 odd times. What could we be, how could we be supporting from a finance perspective, or from HR, recruitment, those sorts of areas are the initial thoughts. There's some ideas.
Just general support, as the GPs have their network of support, and I'm conscious that not all managers have appraisals. They don't, especially if they're a managing partner. There's a who does their appraisal, because they're an equal, and that doesn't apply to all practice managers. No. But I think GPs do have that support network, whereas practice managers don't seem to have it as much anymore. I know the LMC used to provide resilience support, and I don't know where if it is still there, and how easy accessible it is. And I think it's something that would be really valuable, especially now with so many stresses and so much burnout. You hear about it, but it's recognizing it, and what steps are in place to support anybody who's struggling or at the point of burnout and doesn't recognize it. I think
that's really helpful. Thank you. Catherine, you've muted your mic.
I am muted, unmuted. Am I there now?
Yeah, you are.
Thank you, Ruth. That's really helpful to have that overview. I mean, you can see from my background, so I have two hats. I'm a clinician in general practice myself. I'm a paramedic by background, but I'm also the advanced practice lead for the training hub. To complicate matters, that's under the umbrella of the LMC, because they hold the contract for training hubs, I'm sure you know, but just to explain to others. So Karen, yes, the resilience is still there. I can answer that one for you. So the resilience support from the LMC is still available. I think what's really interesting for me is listening to where the GPSU is going, and seeing what we can do. Like you said, training hub, we're very keen to incorporate comms, not duplicate work, all work together. And I think that's the reason I've come along today, is just to understand more and really start to try and build those links. We're all really keen to do so, because I mean, look how confusing it is. If you were to look in on this, what's the difference between the GPSU, the training hub, the LMC? It's daft really when you look at the NHS, but that's what we've got. But we do have a lot of resources that would seem to tally very well with where GPSU are heading. So we're all really keen. So really just to sort of say that, I know Eloise is onto the comms with Beth, and that's going to be brilliant, to try and make that less onerous for our practices, but to also get what's needed out there. We do feel sometimes that there's a huge difficulty in actually communicating what we can do for our practices. And that's what we need to overcome. So we're really trying just to do
that, aren't we, Catherine?
I think we've got a lot of goodwill going in the right direction, but it's just how we're going to do it, isn't it? And I think that's what's going to be really interesting to see what happens with all the changes currently. So
absolutely. Thank you. Chris.
Hi. I just wanted to say I moved to Somerset in 2023, having previously worked in Bristol, so have a lot of experience of working alongside One Care, obviously an organisation that you will be very familiar with. And just interested to know, if that's the kind of direction you want to move to, because I find them to be a very, very, very supportive organisation. They offered the mentoring programme for new practice managers, which is obviously something that's been mentioned today, which was very invaluable to myself. But the critical difference is that One Care was set up pre-PCNs and were very well established before PCNs. So I'm kind of intrigued to know how everyone will slot in together amongst the various layers that we're creating there.
No, thanks, Chris. And just for everybody else to say, I set up and then was chief exec of One Care in Bristol, North Somerset and South Gloss. And I think GPSU has got a slightly we are similar but different, coming from a slightly different place. And as you say, post PCN, when PCNs came into place in Bristol, we already had that GP to one care relationship. So we had to work out how we were going to bring PCNs into the conversation. And actually, we're almost doing it the other way around in Somerset, PCNs first, but actually, no, we've got to make sure we're connecting really well with practices. We've got to go back to the roots of who our shareholders are. So I think we're aiming in going in the same direction of travel. I think what's going to be interesting is looking forward to neighbourhood contracts, how we as practices work out what our natural neighbourhood is, which might be different to our PCN footprint, and it might be bringing a couple of PCNs together into what is being now called the natural neighbourhood and a geographic footprint versus the PCN. And we don't know either what the future of PCNs is going to look like. And one would probably assume that the PCN funding is going to come through these new single multi-neighbourhood provider contracts. So I think that's why I'm really keen that we're on the front foot and thinking together, talking together, aware of the changes that are coming at us really very quickly, but sufficiently for us, for me, sufficiently rooted in general practice that we can be confident we're doing the right thing for general practice, because that's what we are, and the patients that you serve. So a very roundabout way of answering the question, Chris. I don't know if that is helpful at all. And I guess
no, it's you know, it for a large extent, it is kind of watch this space and see how things naturally evolve. But it's a time of a lot of change at the moment, a lot of sort of big steers in other directions. So yeah, I mean, just because something worked in the past somewhere else, you know, absolutely right not to totally replicate, but yeah, just intriguing situation, I think.
And I guess I'm me, so I would I won't, well, I'll find it difficult not to be me, or for the culture or my values to not be part of the organisation that we're building. But I think it's focusing on what's the right thing for Somerset.
Good.
And I think we're also in this interesting place where we've got an acute trust that is also delivering the community services and mental health services, which means there's an even greater need for a cohesive general practice to balance the conversations in what's now being called our place in this new cluster. And in order to do that, again, we need to be coming together, talking, understanding one another, so that we can amplify all our diverse voices into those conversations in the wider system, along with the LMC, definitely with the LMC.
Thank you.
I keep thinking of things I wanted to say and then they go. Barbara, do you want to talk a bit about the clinical reference group?
Sure. Yes. Yes. Thank you. Yes. And I think I just mentioned, so Karen, you mentioned obviously the Careers Plus, which actually I'm so pleased you mentioned that, because this is the first time we've run a non-clinicians program, and in fact we were so overwhelmed with requests that we're actually doing it twice. So we've got two cohorts, and it'd be really good to have the feedback to see whether it's fit for purpose, if it's what, you know, the non-clinicians need, for example. So just a sort of shout out to say, you know, be really interesting to see with regards to support for practice managers and deputy managers, etc., whether that is fit for purpose and what it does what it needs to do for you all. So just to sort of shout out to that. With regards to the clinical reference group, yes, or what else they need, yeah, absolutely, Rose. It's an evolving, isn't it? We're learning all the time. We learn from our experience and the feedback, most definitely. So the clinical reference group, we were asked to set up a clinical reference group. Again, Ruth talked about balance, and from a general practice perspective, and from a clinician's perspective, balance with regards to clinical pathway design. So there are lots of pathways, as you probably know, and if you've ever been on TeamNet, you'll see that there are hundreds of them out there. But actually a lot of them have been developed, mostly, if not all of them, via NICE guidance, based on NICE guidance and other national guidance. But a lot of them have been developed without much input from general practice on the whole. There have been there have been areas where actually we have been involved. So we were asked to develop a clinical reference group to help sort of redress that, help look at some of those pathways to make sure that they're sort of fit for purpose for general practice in Somerset. So we went through a sort of selection process, and we wanted just a selection of nurses, GPs and allied healthcare professionals, so pharmacists, paramedics, OTs, mental health nurses, etc. We wanted a nice balance of people, and I think that's what we've now got. So we've got 9 people on our clinical reference group, 2 are nurses, 2 are pharmacists, and the rest are GPs. And we're looking at developing or reviewing a clinical pathway. The first one we're looking at is celiac disease. Excuse me, I'm going to cough. You have to excuse my voice. I'm quite a bug. But we're looking at celiac disease. It's a fairly simple pathway, but needs a bit of tweaking, and that's what we're working on at the moment. So, excuse me. Obviously, the outcome of that we will share. We are just a small group of clinicians, and actually we can seek more specialised advice if we need it. We'll obviously be working with our acute sector colleagues, we'll be working with the LMC as well. But the hope is, the hope is that we will be able to develop these pathways that will be relevant and up to date, that we put onto TeamNet. We will obviously monitor them and make sure they continue to be relevant, and they can be used by your clinicians to obviously work patients through a clinical pathway from diagnosis through to ongoing treatment and monitoring, and even indeed into referral into other services. So yeah, it's all brand new, and we're all starting to work together, how we're going to work together, because obviously we're all remote because we come from all parts of Somerset. So we're working it out as we go along, but we have started.
And you're also involved in quite a lot of significant other primary secondary care interface conversations, and some of the sort of nuts and bolts of making oiling that interface, such as discharge letters. Yeah, I'm sorry, Barbara, that you're struggling with your voice.
I'm so sorry, I do apologise. Typical, isn't it? Sorry, I'm just going to take a drink a moment.
Have a drink of water.
Yes, so very much trying to provide a voice, trying to act as that sort of conduit between some of the information with regards to the interface work. So discharge summaries. I'm sure lots of you have been in the system probably for as long as I have. And discharge summaries have been an issue for years. And actually, we really need to get to a point where we finalise a standardised template. We need to improve the quality of discharge summaries. So we're working, particularly with Somerset Foundation Trust, to try and make sure that happens. And they've done an awful lot of work. And we're just trying to make sure that actually what's developed is right for us as well. So we're doing a lot of work with that. We're working with things like discharge medication, TTOs, making sure again that that is maintained and consistent, because the last thing we want is patients to be discharged without adequate supply of medication. You know, we get emergency requests for medications, etc., etc. So again, we're working very closely with that interface to try and make sure that there's an easing of that process. Same with fit notes, as you know, lots of issues with fit notes. Patients coming out either without a fit note, calls the GP practice, wants a fit note. Actually, the clinician in the hospital should supply the fit note for the length of time that that patient needs it. A really good example was a patient who'd had a joint op, and actually they'd only be given a fit note for a week, but in actual fact they can't work or drive for 4 weeks. actually that patient should have been given a footnote for the 4 weeks. So essentially, so we're trying to work again, particularly with SFT, and we will be looking obviously at RUH as well for our sort of northern practices to try and make sure that we work with them to try and ease some of those processes. So it's all to benefit patients, isn't it? At the end of the day, it's to make their lives easier as well as our own as well. So there are lots and lots of examples, and I'm very happy to share them as we go along.
What about the issues log? Encouraging this, we're going to put this in our next bulletin, aren't we? But really making sure practices know about
So I don't know if any of you are aware, you probably are aware, but there is an issues form that anyone can fill out. And this is for SFT rather than RUH, I would just mention. But there's an issues form. So if there is a specific issue that you've come across, be it, you know, poor referral, lack of communication, medication, you name it, there is a form that you can complete, submit it, and we will send the link to that issues form. And then SFT collate those, and then as a group we review those and we look at the trends, and basically we try and work out how to remediate those issues. Perfect, thank you. On the bulletin, yeah, absolutely. So the issues forms are really important because it's our way of communicating with the trust and telling them what we think has gone wrong and what needs to potentially be fixed. So we have said that we will make sure that we continue to promote the issues form for, you know, clinicians and non-clinicians, practice managers to use, because the more we can document what the main issues are for us and our patients, then actually that means we can do something about it. We can raise the issue and actually then tackle it. So yeah, so we will share that in our next bulletin as well, and I click on the link to that full.
And there's one other thing that is quite new and hot off the press that we wanted to share, which is the go live of the COVID medicines dispensing unit, the CMDU, which again, sorry, Barbara, I feel that I'm asking you to do lots of talking when you haven't got any voice.
No, I'm sorry. Yes,
I'd get it wrong if I talk about it.
This is really exciting. So I'm sure you're aware that previously we had an oral antiviral. This is for COVID positive patients who are on the vulnerable list. They had the opportunity to be assessed and prescribed oral antiviral agents. Obviously, if they're poorlier, then there is the opportunity for them to have IV antiviral drugs, although that service will be stopping early next year, I believe, nationally. But for now, if patients are unwell, they can be triaged and assessed for antiviral agents, which should hopefully stop them getting sicker and requiring admission or becoming or deteriorating and becoming more poorly. So that service was run via HUC, via the 111 service. We take over that service from the 1st of November, Saturday, 2 days away. And we'll be working with an organisation called BrisDoc, who are obviously based in Bristol, but actually are much more local than HUC potentially. We are bringing it back into the region, and we are working closely with BrisDoc to offer this service. It's a 6-day a week service, and GP practices can refer via, there's a form that you can fill in and then submit via an email address. And then our plan is to triage and assess those patients, hopefully within 24 hours, and then check if they're eligible for drugs and prescribe them. Or patients can go through 111, for example, if need be, or they could actually self-refer as well. I think most will probably come through GP practices. I think we have let community pharmacies know, because sometimes patients might pitch up asking even our community pharmacists where they might get the drugs. So again, we've notified them, and we will let our SFT colleagues know, so that clinicians, oncologists, etc. in the hospitals can actually remind patients that they might be eligible for the medication. Great, and there you are, Kira, fantastic, what a double act. She's now putting the link on TeamNet where there is information about the service. But basically our go live is Saturday. You shouldn't notice too much of a difference. It's just that you will send the form to a different sort of inbox that's been developed with the ICB. and then there'll be a hopefully swift review of your patients. Any feedback that you've got, we would love to hear it, because again, there's going to be bumps in the road with any change of service, but if we can do things better, or if you think we can do things better or in a different way, we would love to hear from you. And actually we want to learn from that and try and make this, you know, a really good, efficient service for our patients and for yourselves. Does anyone have any questions about that?
No questions for you, Kira, but thank you. Should we move on to the question in the chat? Kira, can you unpin?
Yes, I can. Yeah, not a problem.
Please, I'm confused. Oh, thank you. Question about GPSU remit to apply to national programmes for, yes, very definitely. We are very keen to work to secure funding for programmes with practices. An example of that is that Barbara's been, I won't ask you to talk again, and we can talk about this another time, to bid for some research funding from the national team. We supported the NEHIP bids, although we weren't successful in those bids, but I'll come on to that in a minute. So yes, is there anything particular that we might be doing? What we have applied, we've already applied for that.
Yes, so that's the
Yes,
obesity
of course.
pathway. Yes, so yes, we have, just to
Sorry.
reassure you. Yes, I know, we're sorry, no.
There you go. I knew
it's-
that. I did know that.
Yeah, so yeah, absolutely, we were on that one, and yes, we have sort of, yes, agreed and helped support that. Yeah.
So that's a bit of watch this space, isn't it?
It is, we're just waiting to hear, yeah.
Waiting to hear, yeah. And I think we're getting a reply to that. Brilliant. I also just wanted to mention, and we just touched on the NEHIP bids that went in and we weren't successful. Claire Fuller, Emma, we were at breakfast with her on Monday, and she hinted that actually it might be better not to be part of that national programme because there was no additional funding with it, and we would have quite a lot of scrutiny from the national team on that. But on the back of those conversations, I think we are now wanting to move into supporting PCNs and practices coming together to work out what your natural neighbourhood might look like, what a person in the street would recognise as being their neighbourhood. So we're just working with PCNs across the county to have, we're aiming to have 4 or 5 local evening sessions, bringing all the practices together to say what might your neighbourhood look like, what would you want it to be, what are the existing relationships, so that we can be on the front foot and start to determine for ourselves what that neighbourhood might feel like or look like. The risk is if we don't do that, then very quickly we'll have the local authority and SFT making those decisions for us, and there are already lots of conversations going on at a system level about what neighbourhoods might be. But I think it's really important that from the ground up we are shaping and influencing those conversations ourselves. So for I've got my map of the county for South Somerset practices, we've got an event on Tuesday, this coming Tuesday evening, the 4th of November. For Taunton and West Somerset practices, so Tone Valley, West Somerset, Taunton Dean and Taunton Central, we've got something on the 19th of November. And I'm just talking to Harry Smallwood and others about what we might do in Bridgewater and North Sedgemoor. So just watch out for invites to those, or talk to PCNs, or come back to me if you'd like to really move those conversations forward, because I think we've got a small window of opportunity that we need to really take the opportunity to get involved. Karen.
Was there anything for Mendip?
Yes, Jackie and I have got a conversation. It's either today or tomorrow to try and put a date in the diary and bring you guys together.
Lovely, thank you.
Yes, definitely. And I think that's also going to be an opportunity for us as GPSU to say what we're doing and what value we could add to those conversations, and how we might potentially be we're waiting for those model frameworks or those new single and multi-neighbourhood contracts to come out later in November. But, you know, what might the contractual arrangements look like, and how could we be working with you to support you in that, and not just assume everything's going to go to SFT. So I think they're really important conversations to have.
Ruth, can I
Yes.
just ask, because again, I don't know, there's so much talk about neighbourhoods and things, and it'd be quite confusing about terminology and what it is.
Yep.
And I know that you're really working hard, and part of these visits and, you know, these meetings that you're setting up is trying to discuss all this. But I presume that, so nationally we're not behind sort of anyone, are we? We're not sort of, but we do need to have some pace, as you say. Actually, we've got to come together as general practice in Somerset to try and make some of these decisions. Is that what you're saying, that we really do need to start agreeing how we might work together as a neighbourhood and what that might be? Because otherwise it'll be taken out of our hands. Is that right? Is that kind of...
Definitely.
Yeah, so we really need sort of strong attendance, by the sounds of it, at those events,
Yeah.
to have that really good discussion about how we might actually steer our own destiny rather than be done on to. Kind of, we probably need to.
Yeah, definitely. So I'm hoping that we'll have all these conversations before Christmas. So Karen, hoping that we might get something in the diary for Mendip sooner rather than later. And also, I guess we've mentioned the RUH briefly, or we've mentioned the RUH this afternoon. I'm also talking to Western and about how we interface with them or don't, and how we can engage with them. They've got a new managing director at the hospital who's very keen to, particularly for Bridgewater and North Sedgemoor practices, work out how we could have an initial conversation around what's working, what's not working, what priorities might be, and bring some of the Western practices into that potentially, so that we can understand how they're interfacing with Western, and you know how we might work across the border in a slightly different way. So I'm just aware there's so much going on, and I could talk forever, and we are running out of time, and this feels as though it's been a bit ad hoc, but it's our first go, and I don't know, maybe we need to be theming these moving forwards or sharing some best practice. I just really appreciate your feedback on what's worked, what hasn't worked, what would have been more helpful. And I'm also really keen to come and meet practices, come out to you and talk to you where you're at, because I think this engagement, having these relationships, direct relationships, is just so important, really, really valuable. Any more thoughts, any more questions? If not, I'll leave you to get on with your afternoons, and thank you again for your time.
No, fully supported by me, Ruth, and I would absolutely encourage all the PCNs and any clinical leads and project practice managers to kind of connect with GPSU and make sure we write the detail of these intentional pathways we are being driven down. But we've worked quite closely with GPSU as the pilot sites with Froome, and forming the neighbourhoods is actually a lot more organic and iterative than you believe it is. It's a really refreshing and new way to approach the way we're building healthcare services going forward. So totally recommend keeping these positive working relationships and these contacts together.
Thanks, Emma. Thank you.
No problem.
Thank you all. And yeah, hope to be in touch soon, or hear from you, or see you soon. Thanks, Catherine. Likewise.
Thank you.
Thank
Thank
you.
you.
Thank you.
Bye.
Bye. Bye.